Welcome to Nursing 142, Chapter 22, Care of the Patient with Head and Spinal Cord Injuries. Traumatic brain injuries are a common cause of injury and death. So for today's objectives, we're going to describe the types of injuries that result from these head injuries. We're going to compare and contrast the signs and symptoms of subdural hematoma and epidural hematoma. We're going to explain why an epidural hematoma causes an emergency situation. We're going to discuss the type of procedures performed to relieve subdural hematomas. We're going to illustrate the pathophysiology of increasing intracranial pressure in a patient who has experienced severe head injury. We're going to identify the reasons why an elderly person is more at risk for intracranial bleed from a head injury. We're going to explain the possible ramifications of spinal cord injury, list appropriate nursing interventions, and analyze the symptoms of low back pain and how they correlate with their causes. Okay, so the most common traumatic brain injury is a simple concussion. But concussions themselves are not simple. A concussion is described best as a closed head injury in which there is a brief disruption of the level of consciousness. Amnesia often occurs with concussion. The seriousness of the concussion can be correlated to the length of time that the loss of consciousness occurred. The longer the loss of consciousness, the more serious the concussion can be presumed to be. And concussions can cause long-term deficits, particularly in reoccurring concussions. You see this often in football players, which results in chronic traumatic brain injuries over time, sustained again and again, will lead to overall brain damage. Other injuries of the head include skull fractures. They can be described as linear or depressed, simple, comminuted, compound, closed, or open. So now we've discussed concussions and skull fractures. Next, let's discuss contusions. A contusion is simply a bruising of the brain. The brain tissue is bruised. And like any bruising, there's an accumulation of blood that occurs. However, the brain is in a confined space. It's encapsulated by the skull. So any additional accumulation of fluid can cause an increase in intracranial pressure. This itself can be bad. Now, when you bruise your brain, since your brain is floating inside your skull in cerebral spinal fluid, if you slam it against something hard, it'll slam forward and hit against the front, but then it'll slosh back. This is known as a coup counter coup injury, because when it sloshes back, it slams against the back of the skull. So you can see in this diagram, figure 22-1, which is on page 501 of your book, you can incur a coup counter coup injury by the force going forward and your brain going forward and hitting the front of your skull, but then it sloshes back. So if you ever notice when you're driving down the road and you hit your brakes too hard, how you go forward first, but then all of a sudden you hit that resistance, that complete stop, and you slam back against the back of your seat. That's the same type of effect that is occurring. So what can occur with all this going on? Well, it can lead to common injuries known as subdural, epidural, and intracerebral hematomas. A subdural hematoma is a common result of a head injury. Common in elderly patients that are on anticoagulants because, well, they're at a greater risk because they bleed easier. It's just simple for them to bleed. An epidural, now that's more rare. You don't see that, but when it does happen, it's usually after some type of trauma, and it's a rapid leakage of blood, usually from an artery. Subdural hematomas are usually venous in nature. Epidural is usually arterial in nature. The epidural is more dangerous because it leads to a very quick, rapid increase in intracranial pressure. Now, and it's the most common artery is the meningeal artery, where you see. Then, of course, you can have bleeding throughout the brain. Like an aneurysm might rupture, and boom, next thing you know, you got an intracerebral hematoma. So remember, a subdural hematoma is underneath the dura mater, underneath the dura layer of the meninges. So that would be, you can see, hopefully I can make this work, you can see the dura mater, and then the blood is underneath the dura mater. Okay? Now, epidural, so with an epidural, you have the bleed is above, where with the sub, the bleed is below the dura mater. The epidural, it's above, epi, above. And right there's your bleed. There's your dura mater. So the bleed is above the dura mater. Okay, remember that's typically arterial in nature. And finally, any bleed that occurs within the brain tissue itself, well, that's an intracerebral bleed. So there you go, your various types of bleed. Neurological signs and symptoms that you need to look for. Well, obviously, there are numerous, but periorbital fractures, which can result in a bruising underneath both eyes. And it's called raccoon eyes, which is, makes sense because the patient looks like a raccoon. Because you see this in someone who maybe broke their nose and you see they've got two black eyes. All right? So it's common in skull fractures where you have, especially periorbital skull fractures. So you have raccoon eyes. Another common one you'll see is when the bruising occurs behind the ear, and this is called a battle sign. I've seen this in Iraq and Afghanistan because of concussive injuries that occur with explosions, and hence that's actually how it got its term battle signs, because it was very common in World War I to see these bruising behind the ear with this intense bleed. Typically, if you have the raccoon signs, you want to think that the fracture is more anterior. So if they have a basilar skull fracture, you're looking at an anterior basilar skull fracture with raccoon signs. If you have battle signs, you're thinking more posterior. So they may have suffered a posterior basilar skull fracture with battle signs. And battle signs is a more severe injury with a poor prognosis. Now, often what accompanies these head injuries are ureas, okay? This is drainage from areas that shouldn't have cerebral spinal fluid draining. Otorrhea, draining from the ear. You shouldn't have fluid coming out of your ears. Rhinorrhea, well, typically, cerebral spinal fluid doesn't come out your nose. So if you have fluid coming out their nose or their ears, what you want to do is you want to perform a halo test. Okay, you can look on page 502, figure 22-4, and you just take a little bit of that fluid and you drop it on a 2x2, and you can see the blood accumulates to the center and the cerebral spinal fluid will go to the outside, creating what looks like a halo. And that's where you get that term halo test. Also, cerebral spinal fluid is very high in sugar content. So you can take a glucometer and you check the sugar. If it's really, really high, then you can suspect that it's cerebral spinal fluid as well, because if it's mixed with blood, you can't really tell that it's cerebral spinal fluid. It might just look like blood. In addition, these patients often suffer from tinnitus, this high-pitched ringing in their ear, or they might have hearing difficulty altogether. They could suffer from facial paralysis like you see in a stroke, because let's face it, a stroke, what did we just talk about? Epidural, subdural hematomas, those are strokes. And consequently, facial paralysis is one of the things you consequently see. So, conjugated deviated gaze, where their eyes are almost stuck to one side, looking to one direction. And whenever you suspect somebody has an intracranial pressure, increased intracranial pressure, or possible bleeding into the cerebral spinal fluid, almost always is going to be accompanied with some type of nuchal rigidity, neck pain with flexion. So if you ask them to put their chin to their chest, they don't want to do this because it causes severe pain in their neck. And so nuchal rigidity, that's why nuchal rigidity is one of the common tests you do for meningitis, because if the meninges are inflamed, they're sensitive to that stretching when you put your chin to your chest. So putting your chin to your chest causes a pain, which is a positive nuchal rigidity sign. Okay? So what do you want to do? You want to monitor the progression of their level of consciousness. Now look at box 22-1 on page 502. You're going to see, and you're going to need to know, the different levels. What alert? Alert means to respond appropriately to questions and commands with little stimulation. Confused. They're somewhat disoriented to the surroundings, time, people. Judgment may be impaired. They need clues or cues to respond to commands. They're lethargic. Be careful using this term. This really means that they're drowsy, but they're easily aroused. They need gentle touch and verbal stimulation to attend to commands. Obtunded. They're more difficult to arouse and respond very slowly to stimulation. They need repeated stimulation to maintain attention and to respond to their environment. Stuporous. Responds to vigorous stimuli only and may only moan or mutter in response. And then finally, comatose. No observable response to stimulation whatsoever. Make sure you review these definitions and you understand the difference between all of these terms used in the progression of level of consciousness. Now, with the hematoma, especially subdural hematomas, you have different types. You have an acute subdural hematoma, which occurs acutely within 24 to 48 hours. Then you have subacute. Now, this can be 48 to 2 weeks. And then chronic, more than 20 days. You're like, chronic? How can you have someone with chronic subdural hematoma? Well, remember said, subdural hematomas are typically venous in nature. You have somebody, an elderly geriatric patient, they could actually have a very slow leak from a bleed, like a aneurysm that has a small ruptured a small hole in the in the pipe in the tubing, and they got this little bleed that's going on, and they can have severe little mini strokes and with minor or very little deficits, and then finally work up to the big major stroke. So you can have acute on chronic, where they've had chronic bleed over time, and then finally the aneurysm ruptures completely with an acute major subdural hematoma. All right. In addition, signs of epidural hematoma, well, they include unconsciousness at the time of injury, and someone hits their head, like they're snow skiing and they hit a tree or something, or they fall and they hit their head. Then all of a sudden they'll have this brief lucid period, and where they're good to go. They seem to be fine, and you're like, oh, okay, I guess you just hit your head really hard. And then later on, several hours later, they start to have decreasing level of consciousness, severe headache, nausea, and vomiting. Those are huge signs. And they'll have dilation of the ipsilateral pupil. Now, when people have strokes, they have hemiplegia, okay, on the contralateral. That's the opposite side of the stroke. And then they have pupil dilation on the ipsilateral, which would be the same side that the brain is actually injured. Okay? So remember, the pupil will show you the same side of the brain. The actual paralysis occurs on the opposite side of the brain, contralateral. Okay. Now, diagnostic tests, the most common, obviously, is, the CT. I know you're thinking the skull, X-ray, but that's if you're thinking they have a simple fracture. If you're checking for a bleed, the most common thing you're going to do up front is a CT. An MRI will give you a clearer image, but it takes so much longer to do. And CT is fast, and it's gives you the information really, really quick. So you can get an MRI. You can even get a PET scan, a positron emission tomography, which is very detailed, but also not timely. So what you need, what they teach with strokes, they teach fast, right? And the last thing is time. This needs to be done in a timely manner. And then finally, you can do an EEG, an electroencephalography, and that the electroencephalography determines the electrical waves and currents. In other words, your brain waves, to make sure that they're functioning and everything is sparking as supposed to be. So you can see that is actually an MRI, not a CT. And it's a CT you're going to do in a real quick emergency situation. And that's a EEG. Now, treatment. What are we going to do? Well, we're going to do all measures that we possibly can to keep the intracranial pressure from rising. Let's face it, in serious head injuries, that's going to want to happen. The brain tissue is going to swell. You're going to have limited space. Anything that takes up, more space, then you got brain, blood, and cerebral spinal fluid. That's it. So anything taking up more is going to cause pressure to go up. Well, how do you maintain the pressure? You want to basically look at and take care of the patient's airway. Number one, you want to make sure they have a patent airway so that they're oxygenating, because any hypoxia leads to brain swelling, which can compound the problem. You want to keep the head of the bed raised about 20 to 30 degrees in correct alignment. Why? You don't want any of the larger vessels to be kinked so that they, start to back up blood into the brain, because you want all that fluid to be able, cerebral spinal fluid and blood, to be able to flow freely so that it doesn't back up and accumulate there in the brain. And you want to maintain close monitoring of the neurological signs, and also you want to definitely get vascular access for drugs such as your diuretics. Okay, so what do? Well, keep in mind, you might have to go to surgical intervention. If surgical intervention is required, you're going to have some pre-op period, but surgical intervention is required. It's usually pretty rapid moving. So there's not much going on with the pre-op. A lot of things that go on with the post-op. The pre-op is everything is designed to prevent the intracranial pressure from rising. Post-operatively, you have to take care of the patient following specific written orders. Position the patient according to the written orders. Make no exceptions. Make sure they're positioned properly to help decrease or maintain appropriate intracranial pressure. So you want to make sure that the neck is kept midline, preventing excessive flexion at the hip. You want to promote venous drainage from the head to keep the intracranial pressure from rising. You only use a nasal suction if there's written order, okay? You never do nasal suction if there's no written order, especially after any type of brain surgery. You watch for any signs of leakage for cerebral spinal fluid, and you make sure that that those areas are monitored closely, which are your nose and your ear, and of course your operative site for where the brain surgery occurred. And you always want to use aseptic technique in this environment, because the last thing you want to do is cause a nosocomial infection to somebody's brain. Okay, so the additional nursing treatments might include comfort measures, medications that are written, but the main thing is you got to closely monitor the patient's neurological status, and you report any changes of their neurological status immediately to the provider, and that's extremely important. So if you're monitoring their level of consciousness, you might be monitoring directly the actual intracranial pressure itself, and that's not uncommon for you to monitor that. All right. Documentation is extremely important in these situations, because a lot of times the patient themselves are not conscious, and you're dealing with family members, so you have to make sure that all the teaching, all the family member interactions has been documented well and recorded. It's best to have the patient, or actually the family member, because often the patient is not of the right mindset because they're impaired due to the injury. So it's often better to have a family member, who's responsible for the patient, to sign for and receive those instructions. Now remember, I said you might have to monitor the intracranial pressure. The normal intracranial pressure is 0 to 15 milligrams of mercury. Okay, when that starts to go up, because any lesion or fluid accumulation that takes up space in the cranial vault can cause an increase increase intracranial pressure. If that pressure starts to go up, and you have to be able to be prepared to report to intervene. The earliest signs of that intracranial pressure is lethargy, a decreasing consciousness. This is accompanied by typically a slowing of the speech and a delaying of the response of the verbal cues. So you have to really understand and develop that baseline with your patient early on so that you can catch that lethargy quick. Remember I told you before, lethargy was an important word, and you have to truly know the definition of that, and it's going to be accompanied with that decreased consciousness, and it's by slow speech and delay in response to verbal cues. So remember that lethargy is drowsy but easily aroused, needs gentle touch or verbal stimulation to attend to commands, and it's one of the first signs of increased intracranial pressure. Now, common classic sign now is your Cushing's triad. Cushing's triad is, well, it's kind of a misnomer because it's actually 4 things, not 3. But remember, the rise is systolic pressure. The widening of the pulse pressure. What's the pulse pressure again? The pulse pressure is the difference between the systolic and the diastolic. And then you're going to have bradycardia with a bounding pulse. In addition, the patient may start to experience tachypnea, rapid irregular breathing. That's more of a late onset because the body's trying to compensate. So look at the rise in systolic pressure, widening pulse pressure, bradycardia. Okay, and then eventually, if it goes unrecognized, which it shouldn't, you can start to get irregular respiratory or rapid tachypnic type breathing. So what do you want to do? Well, first off, you want to prevent this from happening in the first place. You want to provide supportive care to keep the pressure from rising. You want to make sure that you have IV access so that you can give the proper medications, such as osmotic diuretics. Why do you give osmotic diuretics? Well, we want to remove the fluid from the body. You remove the fluid from the body, the concept is that you remove the fluid from the brain. Remember, fluid on the brain, bad, causing an increase in intracranial pressure. So we might have to give other things like Lasix. So we might give, in addition to osmotic diuretics like mannitol, we might have to give systemic diuretics like Lasix, like a loop diuretic. We might want to decrease the inflammation, because we know that the brain itself will swell. We want to give an anti-inflammatory. So it might think like along lines of a steroid like dexamethasone. In addition, these patients have suffered severe trauma. What did we say? That happens to patients who suffer traumatic events. They're more prone to gastric mucosa disruption. So we might find ourselves having to give like a H2 receptor or a PPI, a proton pump inhibitor, to help prevent them from getting a gastric ulcer. So that might also. And then we're going to want to monitor their intracranial pressure, so to make sure that they're maintaining proper cerebral perfusion pressure. Now you have to have a right pressure for your brain to actually perfuse. That normal is pretty much 70 to 100 milligrams of mercury. We want to keep the CPP right at 60 to 70 milligrams of mercury to ensure that the brain is getting adequate oxygenation but not increased intracranial pressure. And that's important. And how do we do that? We do that by monitoring through an intraventricular catheter that is placed by a surgeon, in the brain. Now, sometimes, in addition, you might have to put the patient on ventilatory support. If the patient's put on a ventilator, you're going to want to monitor their end-tidal CO2 to make sure that they're oxygenating properly. And you want to keep, sometimes you want to keep, normally you keep the end-tidal CO2 around 35. Sometimes you might hyperventilate the patient to help for short-term hyperventilation, not long-term, only short-term, to combat intracranial pressure. This has been argued and is somewhat, how can I say, you know, it goes both ways. You'll have some surgeons who will tell you that they just want maintained at normal end tidal CO2, and others who will say that they want the patient to be slightly hyperventilated. It depends on the provider you have. So follow your written orders, very closely, and make sure that you have end tidal CO2 written into the order so that you know exactly where your provider wants you to keep them at. In addition to that respiratory support, okay, through the ventilator, you might have to administer barbiturates. The barbiturates are used for basically to give the brain a break, okay? I mean, let's face it, the brain, like anything else in the body, if it's being used, you can't really shut it off, right? So how do you give it some rest? Well, you give it some rest by giving the barbiturates, and that's sometimes used for continuous brainwave monitoring. And now, patients who have increased intracranial pressure, that pressure starts pushing down on the hypothalamus, which can cause temperature regulation. So they can this can be seen with a fever, or it can be seen with hypothermia. Either way, you might have to find yourself taking control of the thermal control for your patient. So you're going to have to monitor closely the patient's body temperature, and then place either cooling blankets or warm blankets on the patient as indicated to make sure you keep the patient's temperature in the proper range. So, like I said before, how do you monitor? Well, capnometry, you're going to monitor this end tidal CO2. Okay, so we asked the question, why does increase in intracranial edema cause a double threat to the brain? And if you look at the concept map here, all right, you can see it on page 507, the concept map 22-1. You can see that the brain injury, no matter what the cause, whether it be a head trauma, stroke, infection, it causes inflammation and cerebral edema. Now that cerebral edema, that intracranial, why is it a double threat? Well, it causes vasodilation, which causes increasing intracranial pressure. The increase in intracranial pressure causes a decrease in that cerebral blood flow, which leads to ischemia and hypoxia. That leads to cell death, which leads to more edema, okay, which leads to, once it even swells more. So now it swells more. That leads to more vasodilation, more cerebral blood flow. You see it keeps circling until finally that increased intracranial pressure gets so severe, it leads to herniation, which compresses the brainstem. Now it's going to disrupt the respiratory center, because the brainstem is the respiratory center. That respiratory center gets disrupted, and it just continues down this cycle of what? Vasodilation, because the body's saying, hey, I'm not getting enough oxygenation. Increase the vasodilation. Give me more blood flow. More blood flow means more increased intracranial pressure. And keeps on going until finally that cycle continues. It's a cycle of death. We have to break that cycle. So, indications of that rising intracranial pressure. What did we say? One of the first ones. Lethargy, all right? That lethargy, that altered level of consciousness. That's why it's important for you to know those terms, right? On page 502, box 22-1, that describe level of consciousness. Because when it's altered, you have to catch that up front so that you can see that they've got altered level of consciousness. They're going to become restless, excitable. Anxious is another good word, all right, following a period of calm. All right, if you didn't catch it at the anxiousness, then all of a sudden you're going to feel like, oh, they're all better. Well, no, they could be going into a deepening stupor with a decreasing level of consciousness. They're not getting better. You're letting your patient die in front of you. And then all of a sudden, the pressure gets so severe, they have this massive headache with projectile vomiting. And it just goes from bad to worse, because that intense vomiting causes what? Well, if any of you have ever been severely hungover and vomiting your guts out to the porcelain god the next morning, you know that it kills because that increases the intracranial pressure and you just want to die because you feel like your head's going to explode. Well, in these patient cases, their heads are virtually exploding. So you have to, any of these issues, anxiety, right? Anxiousness, lethargy, extreme restlessness, excitability, and followed by deepening stupor, headache, or vomiting. You have to report these indications. They are all severe indications of increased intracranial pressure. Any unequal size of the pupil or abnormal pupillary reactions, okay? Now, that's our late signs, but that's why you do your neural checks so frequently so that you can catch this early. Okay, just like I said, you're looking for any leakage. Remember the otorrhea, the rhinorrhea, any leakage of cerebrospinal fluid or from the surgical site itself. And as we said before, Cushing's triad. Cushing's triad is extremely important to monitor the blood pressure, the rising systolic, the widening pulse pressure, okay, the bradycardia with a slow bounding pulse. And then finally, late signs would be tachypnea, rapid or irregular respiratory pattern. Goals: maintain cerebral perfusion, reduce intracranial pressure, make sure the patient has adequate respiratory ventilatory response or support. If that means you have to put them on a vent for that ventilatory support, then that's what you do. You maintain that end-tidal CO2 at normal. Protect them from further injury. Maintain normal body functions. Prevent any complications. Those complications include things like hydrocephalus, which is an excessive accumulation of cerebrospinal fluid, which can occur after a traumatic brain injury, and this leads to motor deficits. Or diabetes insipidus. So now, diabetes insipidus is not normal diabetes. Don't think blood sugar. Diabetes insipidus is actually where the pituitary, the edema, the swelling actually has an impact on the pituitary gland, which prevents the antidiuretic hormone from being released in adequate amounts. This leads to the patient having polyuria. Now, polyuria is excessive urination, so they're just peeing their brains out, and this leads to polydipsia. So if they're awake, they're going to complain of excessive thirst, and the amount of volume of urine they're going to produce is going to be extremely excessive. So if you have somebody with a brain injury or a head injury and they're just peeing out a ungodly amount of fluid and are really thirsty, you better be notifying the doctor right away and can be prepared to give vasopressin and fluid replacement are the preferred treatments of choice for diabetes insipidus. Now, let's move along to injuries of the spine and spinal cord. A person may suffer from injuries of the spinal cord in, basically numerous ways. You can injure your spinal cord. It could be a fracture, a dislocation, a subluxation. It could be a compression injury, pulling or twisting or tearing of the cord. Any of these, all of these, lead to spinal cord injury, which can result in microbleeding, edema, and loss of function at or below the cord level. Now, the worst is obviously a complete severing of the cord itself, through and through, or a full entire thickness injury of the cord is probably the worst you can get. You can also receive partial thickness or partial injury, or you can also bruise the spinal cord and have what's known as spinal shock, where the cord itself is just shocked. You can have temporary paralysis on the spine. Because you can see if the injury occurs, you fracture your spine, it can sever the spinal cord itself. The vertebrae is a transection of the vertebrae. The spinal cord itself can be completely severed, or the injury can just impair certain nerve roots as they come through and out. So it all depends at the level of the injury and how severe the injury is. Trying to get your little dot. So they fall off a ladder, they can suffer a compression fracture, or they dive into a pool and they suffer a compression fracture. Now that compression fracture on a diving victim is going to be more in the neck region versus a falling victim is going to be more in the lumbar region. So looking at how the injury occurred, but no matter how the injury occurred, no matter what happened, you want to deal with these four main objects. The first thing is you want to save the victim's life. Okay? You want to prevent any further injury to the cord. So you have to maintain careful handling of the patient. This typically results in log rolling the patient. You want to repair as much damage to the cord as possible. That's if possible. And then you want to establish a routine of care that will improve and maintain the patient's state of health and prevent complications. And you also have to give them a realistic view of recovery. So remember, you want to avoid, you want to save their life. So anything you have to do to save their life, which could be respiratory support if the injury is high, and then or possibly even CPR. And then you want to prevent any further injury, so avoid any flexion of the neck. So you don't want to put in pillows or anything like that. You want to log roll the patient, keep them on a hard surface, and you want to make sure that you've got proper cervical spine injury prevention. So you want to make sure that they've got C-spine precautions in place when you're first taking care of the patient. And remember, then after that, it's the routine care to improve and maintain the state of health to prevent any complications. Complications that you want to prevent are things like spinal shock and neurogenic shock. Now, spinal shock is basically characterized by a flaccid paralysis and a loss of reflex activity. Now, this can occur typically within 48 hours and weeks after. It can result with bradycardia, hypotension, and an occasional paralytic ileus. Neurogenic shock usually happens within the first 24 hours, and this is caused by a sudden loss of that vasomotor tone. The body's used to it, and it hasn't learned to compensate yet. So all of a sudden it's lost this vasomotor tone, which kept the blood pressure up, and you get this hypotension and venous pooling. And this hypotension and venous pooling, bradycardia can occur, and sometimes a paralytic ileus. So this results in their vital signs becoming somewhat labile. They may try to compensate, or they may not be able to, depending on where the neurological damage has occurred. Of course, strong involuntary muscle spasms are also a severe complication, and this can lead to contractures and of the skeletal muscles. So you want to be very supportive, and you want to explain that while their life will never be the same, they can still have a life. Now, one of the big complications is autonomic dysreflexia. Autonomic dysreflexia is an uninhibited and exaggerated reflex response of the autonomic nervous system to some form of stimulation. This occurs in 85% of all patients that have spinal cord injury at or above the level of the sixth thoracic. So above T6, you can anticipate this is going to happen in your patient. Now, there's usually some type of stimulating circumstance that's causing it to occur, and it's usually bowel related. It's either bladder or bowel, most common cause. In other words, the bladder becomes distended because nobody has cathed them in a while, or if they have a permanent cath, like a Foley cath, then it might be kinked. Okay, that pressure causes an autonomic dysreflexia. What happens? Or they've got a bowel impaction. They haven't had their stool removed in a bit, so you might have to go and do a digital removal of their stool. This can actually kill your patient. If all of a sudden they start complaining of a headache, they look sweaty, they got goosebumps, their heart rate is elevated, check their blood pressure. Their blood pressure is hypertensive. You gotta be quick, because they can go into a seizure, they can have a retinal hemorrhage from the high blood pressure, and they can stroke. So you need to remove this stimulus. you remove the stimulus. Think bowel and bladder. You go ahead and take care of that, and usually it'll resolve relatively quickly on its own. All right. Now, orthostatic hypotension is a common complication. The vasoconstriction is impaired. Now, normally we have normal vasal tone, so the blood works its way up back into the vascular system. Well, we don't have that if there's got a neurological injury. So this results in pooling of the blood. Consequently, that can result in hypotension. In addition, it can result in severe DVTs because now that blood is sitting, and what does blood do when it's static? It clots. So they're at high risk for that. They're also at high risk for infection. They're at high risk for skin breakdown. That pressure ulcers, those pressure ulcers then become infected. They got, we talked about, catheterization, Foley caths lead to infection. So, once again, so what happens? Constant renal complications, urinary tract infections, which lead to kidney infections. Why? All this, which results in impaired bladder function. So you can see how one issue compounds the next. It becomes this domino effect of complications. What do you have to do? Once again, think about, supportive care, respiratory management, urinary management, that psychological care, and then that grief and mourning. And of course, these are human beings, so they're going to have your, activities of daily life, but they've just lost everything. Their normal life, their normal life has been turned upside down. So you're going to have to address that. And if they're married, what about their sexual concerns? A lot of marriages don't survive. A lot of relationships don't survive these type of injuries. Okay, look at your assessment of the spinal cord, and don't forget, to look at your various things, oxygenation, blood pressure, infection, all the things that we've already discussed. Okay, don't forget to look at your nursing diagnoses, impaired gas exchange, physical mobility, decreased cardiac output, and all the ones you've got. Remember I said these patients are going to be log rolled, so it takes a team effort. Nursing is a team sport. Always remember that. Assignment considerations. Hey, are these the patients you want to delegate to your CNA? I don't know. It might be too much. Although many of the tasks can be delegated, you're putting them in a position with having to assess high-risk patients. That should not be delegated. And you got to remember, this could be a very complicated patient that might take team efforts and help of many personnel on other staff on the floor. All right, well, let's talk about some back injuries. So, okay, the ruptured disc, if you would, or slip disc. Let's face it, back pain has surpassed headaches as the number one thing in emergency rooms. And most causes of musculoskeletal back pain are your acute lumbosacral strain, your instability of the lumbosacral spine, the osteoarthritis of the spine, the intervertebral disc degeneration, and spinal stenosis. This all, resulting in this herniation of the intervertebral disc, which can impinge on a nerve, causing pain. When a disc ruptures, part of the contents squeeze out between the vertebrae, and it can lodge in the spinal canal, as you can see here in Figure 22-14. You've got the disc that's being squeezed or pinched, that's herniating out from its normal location, and it's causing pressure on the spinal cord itself. But it doesn't have to be on a spinal cord. It can just be, as you can see right here, it can be on the root of the spinal cord as the nerve is leaving the spinal cord, and that disc is now putting pressure on it against the vertebrae, and that pain then starts radiating down the back. And it's a common almost a sciatic type pain, where you'll get the pain radiating down the back of the leg, all the way down to the knee. So you have this, can be an acute back pain, which usually occurs from the activity of stress, hyperflexion, or They're doing something, probably lifting inappropriately, doing something they shouldn't have done. It should be, if it's acute, it should be self-limiting, which usually, if taken care of with ice and heat, some non-steroidal anti-inflammatories, should be able to resolve within 4 weeks. That chronic pain is pain that lasts more than 3 months or is consistently repeated episodes over. Now remember, I told you, different textbooks are going to tell you different things. Some textbooks say 6 months, some say 3. Okay, right now, the old textbook of this actually used to say 6 months. So right now, it's saying on page 519, chapter 22, 3 months is considered chronic pain for back pain. All right. Now, as we said, how is this pain going to present? A lot of it's going to present in a radiating sciatic type pain. From the disc itself radiating down the sciatic nerve through the buttocks down to the knee. What can you do? Well, diagnosis, history, physical assessment is extremely important for the diagnosis of this. Straight leg tests are often used. While the patient is laying supine, you have them raise the leg, and if they complain of back pain while doing that, that pretty much confirms, okay, what's going on here with the sciatic type pain. So what do you want to do to treat it? Well, best thing you can do for sciatic pain is bed rest, 2 to 3 days. You want to give ice for the first 48 hours, and then after that you want to go to heat, which could be more helpful. Sometimes ultrasound treatments have been known to help, and transcutaneous electrical nerve, or TENS units, can help with the back pain. But what they really need to do is, because one of the most common causes of back pain is 1, being overweight, 2, poor abdominal strength, okay, poor abdominal tone, poor posture. So what you want to do is you want to get them to strengthen those muscles that actually support the spine. Back strengthening exercises, and so they might need some, therapy, physical therapy. For many patients, acupuncture has been known to work, acupressure, massage therapy. I mean, who doesn't love a good massage, right? But for long-term, therapeutic results, you want to see physical therapy involved with back strengthening exercises. Some patients find that gentle yoga movements are more successful and can be helpful in an exercise regimen for relieving back pain. So whatever type exercise works for them, whether it be a yoga or a physical therapy type back strengthening exercise, you really want to promote that. Unfortunately, sometimes you have to go the surgical route. Why? Well, to cut is to cure. And what you have to look at, you got different types of surgical procedures. A discectomy is performed to decompress the nerve root. This is a microsurgery technique that uses a very small incision through which the herniated vertebrae disc material is dissected and extracted. All right. Now, they can also use a percutaneous laser discectomy, where this is an outpatient procedure where they use a laser to pretty much do the same thing. It's used to cut away and destroy the herniated portion of the disc. Now, if they get really severe and you get multiple discs or vertebrae themselves are degenerative and need to be removed, then you could do a spinal fusion where they go in and they actually remove part or whole pieces of the vertebrae, and then they'll take they'll graft a piece of bone from usually either a cadaver or their patient's own iliac crest, and they'll put it in and fuse 2 vertebrae together. Or they might do a laminectomy, where you can see in this picture where they remove a small piece of the vertebrae, right, and create a window to relieve the pressure of the herniated disc. All those are various surgical procedures that the patient needs. So what do you need to do? You need to remember that at the time of discharge, your instructions need to be clear. On how long to sit, stand, those length of time should be reinforced. The patients have a bad habit, a tendency of overdoing it, and that's why they get into this back injury in the first place. And unfortunately, they become very fatigued and they end up having more pain. In addition, They don't lose the weight they're supposed to lose. They don't do the lifestyle changes that they really need to do to fix the problem. So they think the surgical intervention is going to fix the problem, and they go back to the same lifestyle, bad habits, and they're going to end up with the same results, compounding the problem. So just remember this when it comes to teaching. So after you're done with your patient teaching, just basically make sure you've covered everything. And if you've got any questions on this, feel free to send me an email. And we will cover chapters, let's see, 23 and 24 the following week. All right, so this is the only chapter you have to do this week. You take care. I'll see you in class the following week. This concludes this presentation.